Session number 7, pediatric session. This particular session is moderated by Dr. Devadatta Mukhopadhyay. Over to you, ma'am.
Good afternoon, everyone, respected chairpersons, dignitaries seated here and the august gathering. We'll start our session today right away. A few intriguing topics here. The first topic would be the quintessential tetralogy of Fallows, and it will be presented by none other than Dr. Anil Kumar Singhi. He is a very, very famous pediatric cardiologist attached to Medica Hospital, very competent and our guide whenever we are in trouble. Please, Dr. Singhi, sir. Could you revert to his presentation, please?
Thank you, Dr. Devadatta. You are so kind and generous for the introduction. And my pleasure to be back here and seeing a post-lunch session full. It's again my visual delight. The topic what was given to me is a very, very common and appealing topic. So when I was told to talk on tetralogy, I was thinking what I am going to show. Everybody is aware the two heart diseases we see, VHD, ASD and tetralogy. So everybody is aware of that. So how we can improve upon our understanding of this difficult topic, I wish to run through some of my experiences and taking clue from my Guruji Dr. Shivakumar and Krishna Kumar. So some of the slides I have taken from them, and we have a eco book which is online, so that also can be referred. So long way since Dr. Arthur Fallot described, it's possibly 100 years and more, tetralogy still is the most common cyanotic heart disease we are coming across. 5% of the total CHD and most common cyanotic heart disease, tetra, we all know 4, and it talks about anterior deviation of the conal septum to start with, RV obstruction caused by the anterior septal deviation, unrestricted VHD aortic override, and RV hypertrophy. These are consequences of a single phenomenon. Two more things, variation of these combinations can happen in different way that I am going to run through. Two additional things, at presence of ASD, collateral and LSBC, they have bearing on the surgical management. So when we are imaging, in the morning we were discussing any imaging should start from the clinical evaluation, X-ray, ECG, echo, history, and again back. That if we are missing something, if we are getting some finding which is unexplainable, we should go back to the patient, see all the details, and again come to see the anatomy, hemodynamic, and then plan the treatment. This happens usually with the ECG. ECG does not come in the echo machine. So he is just reminding us we should put the ECG back. Yes. So the views we were, Dr. Devadatta was very nice to show subcostal, apical, parasternal, long and short, and suprasternal. So this is the sequence of imaging, and three big subheadings: this ventricular septal defect, the position usually conoventricular, its extent, usually it's unrestricted. Whether there is additional VHD, will come to that. RVA OT anatomy is again very important, second point, to be evaluated quite in extensive way in fundibulum, annulus, MPA, branch PA, and with Z-scores of the PAs. Third is the aortic valve. The aortopathy of tetralogy is itself separate entity with up to 5 to 10% of the patients can develop significant aortic dilatation and AR. So we should see then additionally coronaries, collaterals, and ASD, LSBC as we were discussing. So to start with, this simple thing gives lot of clue. On the left hand panel there is a typical boot-shaped heart with reduced pulmonary blood flow, saturation less. But the next one is also from an actual tetralogy patient who has 94% saturation, and X-ray looks almost like a normal heart. It's difficult to say it is tetralogy. So though we can have an ideal textbook pattern tetralogy, absence of that does not rule out. So the next one was from a pink tetralogy patient. So Richard Van Praag described tetralogy as actually monology. So it's monology where anterior deviation of the conal septum and maldevelopment of the infundibulum, everything is sequel of the same fact. So it's subcostal short axis view, we can appreciate this is the conal septum which has deviated in the anteriorly, and that is that obstruction created. The anterior deviation of the septum led to this unrestricted VHD. So the same thing in the inflow-outflow view. So if we place our probe 90 degree to the short axis with the cursor placing to the left, we'll get this is tricuspid valve and this is pulmonary valve. We can appreciate this outflow obstruction. The VHD can be seen en face, and this is the 3D of the same thing. We can appreciate this is the sub-aortic conoventricular VHD with this is the conal depth septum which is anteriorly deviated, and similarly one muscle hypertrophy in the specimen is being shown. So inflow-outflow view is a good view to see the which level is the obstruction happening, and we can locate the extent of the VHD, whether there is an additional extent to the inlet or outlet. So this is apical 4-chamber view with little anterior tilt, and this shows the aortic override and VHD. We can appreciate here the dilated aorta and the flow to through the VHD, RV is ejecting to the aorta. The important part for an echocardiographer who is trying to detect tetralogy is looking for additional VHD. In presence of large VHD, it's very difficult to pick up the small VHDs. So unless we are dedicatedly looking at the apical septum or other part of the muscular septum by reducing our color gain, we will not be able to see. So these are the apical Swiss type of VHD you can appreciate dedicatedly seen. These are the muscular VHDs, and that can only be seen if we are looking at the other part of the muscular septum. The importance, as we discussed in the morning, they are very poorly tolerated in the postoperative state. Surgeons should know there is additional VHD if they can redress it. So aortic override, that can vary from 15 to 95%, though classically it is described more than 50%. So I have shown all this in this frame, it's minimally override. In this frame it is 50%, here possibly 50% and above. So these all are tetralogy patients, but the override can be varying. Classically it is described 50% and above. The tetralogy is a spectrum where there can be minimal aortomitral discontinuity. So here this is that aortic valve, mitral valve, and we can appreciate this is mild aortomitral discontinuity. So usually it is less than 5 millimeter. Significant aortomitral discontinuity and aortic override will form it as a double outlet right ventricle TOF like. So the nomenclature will change. The long term effect tetralogy with aortopathy of the tetralogy, I should say, has significant aortic regurgitation. We can appreciate here in a grown up patient, the aorta is almost 6-7 centimeter and reached to the level of a Bentel correction, significant aortic regurgitation. So aortic regurgitation is common, mild, but more than mild can happen in one group of patients. So coming to the different grades of RVOT obstruction, it can be infundibular, annular, valvular, supravalvular, and in different combinations. So here I have tried to put, this is the short axis view, all in short axis view. This is the infundibulum, anterior division of the conoventricular septum, pulmonary artery, and some, it is mainly infundibular here. In the next frame, it is some infundibular with some valvular. Here it is more long obstruction pattern. So individually when I come, this is an example where infundibular and annular in combination. We can appreciate in the parasternal short and long axis, this is that conal septum which is causing some obstruction, and also there is some valvular annular obstruction. The double pattern of the continuous wave Doppler says this dragger-like picture is from the infundibulum. So when we get two types of signals in continuous wave Doppler, we can be sure one significant component of infundibular stenosis is there. So this is more tunnel-like infundibulum. In the short axis, we can appreciate a long tunnel. The images are much down in the screen. Sorry for that. So again, we are seeing the two signals, one dragger-like signal, which is again coming from the infundibulum. So this is an example where predominantly valvar stenosis, you can appreciate here the override is less, obstruction is mainly, and the valve, you can see there is mild regurgitation of the valve also. So this is tetralogy with predominantly valvar type of obstruction. The next category is annular. So there is deficiency of the conal septum. We can appreciate this pulmonary valve directly in the annular level causing obstruction, and this subtype is basically Mexican variety of the tetralogy where deficient conal septum, the whole of the conal septum is absent, so the VHD becomes juxtapulmonary, subpulmonic type of VHD. You can appreciate the whole of the obstruction in the annular region. So this is absent conal septum, Mexican variety of tetralogy. From there we move on to the supraannular region. You can appreciate this some doming valve with supraannular region is very tethered and long obstructive tunnel-like supraannular region. So this is a significant component from the supravalvular pulmonary stenosis. So measurement of the different places, annular, supraannular region, all are important from the surgeon's point of view of repair. After the MPA, we should try to see the branch PA in the short axis as well as from the suprasternal view. So this is the main pulmonary artery continuing as RPA and part of the LPA origin scene. And that's what we are worried at in tetralogy. Significantly hypoplastic branch PA, they are not very good. We should try to evaluate the Nakata index and how much it is suitable to sustain a complete repair. To know it better, we may be required to do a angiogram, either conventional or CT pulmonary angiogram. When it comes to branch pulmonary artery obstruction, the X-ray is always important to know the differential vascularity. So one X-ray, again coming back to X-ray, the right side is completely opaque than left side. So there is less vascularity on the right. The example I have of another patient where LPA was obstructive. So individually seeing the branch PA, again important for the surgeon, he need to augment it, and CT is a good modality to tell the surgeons. They usually insist on CT. This is again a big topic of coronary crossing RVOT because we cannot put a transannular patch if there is a major coronary crossing RVOT. 2 points are important: how big is the branch crossing and how close to the annulus, whether the surgeons can spare it or not. If it is far away from the annulus, then possibly surgeons can manage, but otherwise he may be required to do a conduit repair or something called double barrel repair. Conal branch small crossing is common, but large conal branch 6%. So this is a dextrorotated aorta, right coronary artery coming, and there is nothing significant. But parallelly, in the next frame, there is a big coronary coming out, which is as big as the size of RCA, and that is important, and it need to be redressed. Surgeons should know and be ready with a conduit. So again, a series of images, you can appreciate it was LED coming from big artery, LED across, and surgeons should be ready and accordingly should counsel the parents. Right arch, in the morning there was discussion, Dr. Devika was raising that question. how to see, and in the tetralogy, first branch going to the left and dividing, and second fall of the arch to the right. So this is right arch. It's pretty common. 25% of the top can have right arch, and when right arch is present, the possibility of Dijor syndrome will go up, and that need to be redressed in a different way. So PDA can come usually in the regular position, but if it is atresia, then it will be coming from the undersurface of the arch. This is from an atresia subset. I have not touched the atresia. Collaterals are very commonly seen from the subcostal view coming from the aorta, or it can be seen from the suprasternal view. They increase venous return, and cardiopulmonary bypass time, low perfusion pressure cause more brain injury. So we should know it early and redress accordingly, and it will require coil closure. This is one such example where we have coil closed that collateral to reduce the surgical risk. So PFO, left to right versus right to left shunt, surgeons usually keep it, but they should know it. Left ventricle dominant, very large, this is that dilated aorta of left ventricle I showed, and this is a child from pink tetralogy, more of left to right shunt rather than right to left shunt. You can appreciate in the VHD, it is left to right shunt. So LSBC to the unroofed coronary sinus, an example, the surgeon should redress it, otherwise post-operatively a child will be cyanotic. Absent pulmonary valve is an entity where there will be severe PR along with obstruction, aneurysmal dilatation of the branch PA, and it requires an conduit repair. This is TET canal, tetralogy with AV canal, more common in Downs, and this is a more sophisticated form of tetralogy repair. Accessory tricuspid valve can restrict the tetralogy, and below is the set. It's also called Hoffman variety. This is the tricuspid accessory valve tissue trying to restrict the VHD. Surgeons need to redress the tricuspid valve. This is a long-standing untreated tetralogy leading to RA-RV, dilated RV, severe ventricular dysfunction and pleural effusion. So TOF presented with heart failure. Again, and less common seen complication, late adult tetralogy with heart failure, vegetation. Usually we don't see left vegetation in normal heart, but because of the tetralogy, aortic valve vegetations are there. So this is aortic valve vegetation and sick patient. This is again extremely rare case, tetralogy with hypertrophic cardiomyopathy. You can appreciate, extremely rare. These are just, I'm showing an example, tetralogy can exist in, cardiomyopathy is no bar to have a tetralogy. This Dr. Drito was showing in the morning, so TOF with left malpost great artery with branch pulmonary artery narrowing. You can appreciate left anterior aorta and right posterior PA with significantly hypoplastic branch pulmonary arteries. We did CT to confirm the location of the branch pulmonary arteries. And this is the last, usually two-side obstruction does not happen, but rarely we can come across tetralogy with coarctation, and coarctation was in the thoracic aortic region. Above I could not pick up, it was only from the abdominal Doppler, it was visible. You can appreciate the diastolic spill pattern seen in the reverse way. CT confirmed and we published this. So to conclude, evaluation is tetralogy again in a very detailed imaging in backdrop of all information. Checklist should be made and we should try to look for all points. The kid should be very well sedated. For an appropriate probe is essential, and need of an additional imaging based on the primary evaluation. Thank you.
Thank you very much for this wonderful one, this just brilliant presentation. I just have a small question while we go on to before we go on to the next talk. That is, a lot of these patients will come after operation. So we will be finding a lot of these patients coming as operated off. So could you just lead us through what important points in the echo should we see when the child or a adult comes who has been already operated for the tetralogy?
Thank you. It's a very valid question. I purposefully avoided the talk on post-operative tetralogy because that is itself is a big topic. All the points we tried to redress in the surgery, everything again should be meticulously checked, how the child is doing, coming from the VHD, whether it is completely closed, there is additional residual VHD, whether there is AVVR, which is common because surgeons detach the tricuspid valve, so they may end up causing an TR, whether it is causing trouble. RBOT is how much obstruction is relieved, how much is present, and how much is the extent of the pulmonary regurgitation, because that is going to create future trouble. Whether there is any collateral left or it is giving some trouble, and overall function. So these are the key points we try to look on regular basis, and case to case, the same checklist which was used can be followed up in the index patient based on his anatomy. I think that will be sufficient for the start.
Thank you.
Thank you, An.
Sir.
Thank you, Anil, for your nice presentation. Just a practical thing, often the right ventricular tract assessment gets difficult because there may be very poor flow across the right ventricular outflow, and you may not get a very high gradient, but that does not mean that there is no significant obstruction. So even if there is very poor flow across the right ventricular outflow tract, the gradient may become low, falsely, but there may be a severe obstruction. And the best way, especially in children, is to assess the right ventricular outflow tract from the subcostal view. That often is very helpful.
And in the same line, in the newborns, when we see, there is a term called tetralogy in evolution. So initially, because of the relatively high pulmonary vascular resistance, the gradient will be low. And when we see after 6 weeks to 3 months, slowly the gradient will build. So that's why the term called tetralogy in evaluation, we should keep on a periodic basis seeing we'll get through it. Thank you.
We are going through a little bit of technical issues. Just can we switch to our laptop? Okay, I'll just call upon the next speaker. Dr. Ishita is the next speaker, and please, she will be speaking on coarctation. Okay. Pediatric cardiologist. She is interventional cardiologist in SSKM Hospital.
While we prepare for the next talk, may I just ask Dr. Singhi, probably you purposefully skipped the topic because of the time constraint. The tetralogies with one ventricle small. So what will you do? But how do you assess, and whether you go for a single ventricle correction or a two ventricle correction? What are the
RV anyway is dominant in tetralogy, so will be more prominent. If the LV z-scores is within, say, 0 to -2 up to level, aorta also the same level, then surgical
you
team
mean
combined
the mitral valve z-score?
mitral valve, the LV
Length.
mitral valve to, yes, I'm telling LV mitral valve to LV apex. If LV is coming up to the apex and aortic and mitral z-scores are acceptable, then predictably that heart will take through the biventricular repair. Usually in tetralogy substrate, if we are convinced the VHD is not that big to cause single ventricle, that usually tolerate. But how on post-op they will behave, that only after performing the surgery they can tell.
Because many of the times, especially those surgeons who are not regularly operating on tetralogies, they will be looking at the left ventricle. It is very small. So they will be scared whether the LV will be able to take the load post-operatively or not.
Only answer to this question will come when surgeon will sit with the cardiologist along with the anesthetist in the cath meeting type and discussing the echo, raising all the questions. I think then that will come down.
Are we
I think
ready
Ishita
for
is ready.
presentation? Not yet. And how long are you comfortable to take a tetralogy directly to the operation theater on your echocardiographic basis?
You see, that was the norm in Amrita, sending only on echo. But presently, my surgeon is his personal choice of another imaging.
Right.
Though sometimes it's very difficult to do that many caths. So some of the patients
More
he
of
said
it
for-
is surgeon and institution dependent.
No, not institution. It's surgeon's priority.
dependent.
He is tuned for CTs or cath. Now you cannot do so many tetralogy caths. So some of the patients where it is, they end up doing an CT for their zone of concern. Yes, Dr. Ishita.
Thank you so much. I think we'll move on.
Good afternoon, teachers and my respected seniors and my colleagues. So today I'm going to present before you something called as coarctation of aorta, which has varied presentations. So I will be touching upon the clinical presentations and how you will proceed for the echocardiography and the management part to some extent. So, coarctation of the aorta is one of the most common congenital cardiac anomalies causing narrowing of the proximal descending varying within a range of arch abnormalities from a discrete narrowing to a long segment of hypoplasia. It was first described by Thien in 1760s and accounts for 4 to 6% of the congenital heart defects. It has an incidence of 3 to 4 cases per 10,000 live births, and males are commonly affected than females with a ratio between 1.27:1 to 1.74. So isolated, there is two terms. One is the isolated coarctation and is the complex coarctation of aorta. So isolated coarctation of aorta accounts for 82% of the total coarctation, while the complex coarctation accounts for around 11, which includes whether it is associated with the VSD or the arch anomalies or any other cardiac anomalies which are associated with it. The complex coarctation doesn't have a male to female ratio of 2:1. The survival of pure coarctation is 15%. Heart failure presentations in neonates is around 85%. Survival in late childhood without operation is around 85 and 65% in the survival in the third life defect. So aortic rupture usually occurs in the second and third decade. Intracranial lesions can occur, which is occurring usually due to the berry aneurysm, which is association with the coarctation of aorta. So coarctation types A, B, C, which is the juxtaductal, B, which is the preductal, and C, the postductal ones. So associations most commonly is the bicuspid aortic valve, which occurs in 75% of the cases. And coarctation of aorta has been found to correlation with the left heart obstructive pathologies, like the aortic stenosis, hypoplastic left heart syndromes. It is also associated with cort triatrium parachute mitral valve, which is actually a component of the Schoen complex. Ventricular septal defects, which occurs in around 40%, which can be of the various types of ventricular septal defects, patent ductus arteriosus, double outlet right ventricle, transposition physiologies, AV canal defects, and aberrant arch vessel anomalies, of which the aberrant left subclavian artery origin is very common. Non-cardiac importance is the Turner syndromes, which are very commonly associated with coarctation, aortic aneurysm syndromes, Faces syndrome, William-Buren syndrome, Alagille, Noonan, and cerebral artery aneurysms and other aneurysmal syndromes. So case 1, I will touch upon the cases in a short. Term baby, which was delivered normally and cried immediately and was discharged on day 3 in a peripheral hospital. It was readmitted in a collapse stage on day 7 of life with cold extremities, femorals were feeble, metabolic acidosis with increased lactates, and after the patient was stabilized with prostaglandin infusion, the upper limb BP was high in comparison to the lower part, and the femorals were feeble. So this was the X-ray which showed a cardiomegaly with decreased blood flows, and the ECG showed a right axis deviation. So the echocardiography showed a right axis deviation hypertrophy with the LV showing hypertrophies, and the LV also is hypertrophied in comparison to the age, So this is the suprasternal view, high parasternal view in a neonate, which is a high parasternal view, which shows a narrowing in the in the descending part, just distal to it, and the Doppler integration showed a gradient with a diastolic tailing, which was easily could be viewed. So the patient was put on prostaglandin infusion. The diagnosis was critical coarctation of aorta with PDA-dependent circulation, bicuspid aortic valve, no aortic stenosis or regurgitation, no arch hypoplasia. So surgical treatment with end-to-end anastomosis was done. The follow-up was with lower limb pulse palpation, upper limb blood pressure monitoring, using appropriate cuffs, echocardiography at intervals, and CT aortogram when these first lines were abnormal or prior to the next interventions. So learning from this case is palpate the femorals, dorsalis pedis, pre and post ductal saturation check before discharge is must for neonates. If a baby presents with poor feed and shock by day 7 or 10, start prostaglandin infusion. Immediately think of coarctation and call your cardiologist. Surgery is the option for neonatal coarctation. Only if the patient is in very sick condition, we go for balloon, though it's a 2A indication. So the next case is a 1-year-old child who was having severe respiratory distress for the last 3 months, treated as dilated cardiomyopathy, present with have failure to thrive. The birth history was uneventful with recurrent hospitalization after 3 months of age. The body weight was also very less with not gaining properly. The respiratory rate increased. The apex weight was little lowered down with feeble lower limb pulse and a systolic murmur was audible. So the X-ray was also showing a cardiomegaly globular heart, and the ECG showed increased left ventricular force as well as the left axis deviation. So differential diagnosis in a baby with dilated cardiomyopathy, first is foremost is the myocarditis. Metabolic causes to be ruled out, that thyroid problems, hypo or hypothyroidism, hypovitaminosis, idiopathic, genetic, coarctation of aorta, the two things which comes for an echocardiography to rule out, because these are treatable causes. One is the coarctation of aorta, anomalous left coronary artery origin, and also the interrupter. So the echocardiography of this child was a globular heart in which we can see the dilated left atrium and the left ventricle with a large, and EF was very less, around 17%. There was a turbulence noted in the descending thoracic aorta at the proximal level, and there was a suprasternal sagittal showing a tailing with diastolic tailing and a gradient. In the abdominal aorta, if we keep the parallelly these lines, and we see that there is a truncated systolic flow as well as the diastolic overflow is there, diastolic spillage, and these point towards the aorta. So a cath was done which showed a significant narrowing in the descending thoracic aorta with some collaterals which we can see. And now balloon dilatation was done at this level, and after dilatation the gradient, which was 60 millimeter mercury, initially came down to be 10, and so the diagnosis came on the severe post-subclavian coarctation of aorta with severe left ventricular systolic dysfunction. The patient was discharged on beta blockers, AC inhibitors, and diuretics, and in the follow-up of around 3 and 6 months, it gradually increased the contractility, and hypertensive medicines have been tapered, but still AC inhibitors and these are going on. So learning from these cases, neonates or infants who present with heart failure or is a follow-up case of dilated cardiomyopathy, rule out coarctation of aorta, L-kappa from echocardiography. Transcatheter interventions play an important role in infancy, unlike in neonates. Detailed clinical examination and detailed echocardiogram is very important in diagnosing coarctation of aorta and arch abnormalities. So the third case is a 13-year-old boy who was completely asymptomatic, was complaining of headache, for which he visited the doctor. Eye checkup was done, and suddenly increased pressures were noted. It was around 156 by 94, and in usual follow-up for a hypertension came to the cardiologist, and where we got a systolic murmur in the upper sternal region, and we did an echocardiography, and which showed the X-rays also showed a notching in the third and fourth, as well as there was a left ventricular hypertrophy and the echo showed a concentric hypertrophy at this age, which was higher than that of, it was 12, was critically more than that 13 years of age. The aortic valve was normal, as whenever we get a concentric LVH, the things which are obstructive, that is the aortic valve and the aorta, we have to see to it. The echocardiography showed diastolic tailing with a gradient of around 61 systolic gradient, and in the abdominal aorta, it showed the same truncated appearance. CT was done to rule out any other obstructions or not, because at this age, so it was only a smaller focal one, and this was planned. MRI angiogram was also done, as we know, berry aneurysm is usually associated with a coarctation of aorta. Antihypertensives were continued and planned for balloon dilatation with stenting, as the weight was more than 25 kilos. So it was another which is stenting. And to summarize, so goals of echocardiographic examination: coarctation best visualized from suprasternal notch view with 2D color and spectral Doppler imaging. Obtain a peak velocity with a mean pressure gradient across the transverse arch and isthmus. Flow will often be high velocity with persistence of flow into diastole. Identify arch-sidedness and branching pattern of head and neck vessels. Assess for distal displacement of the subclavian, left subclavian artery. Obtain precise 2D aortic arch measurements along with Z scores, the ascending, proximal transverse, distal transverse, and the aortic isthmus. Determine if there is an isolated coarctation or diffuse transverse arch hypoplasia. The arch dimensions: diameter of the arch, distal transverse arch, and normal in newborns is the weight in kg plus 1 for the proximal and weight in kg for distal arch. And then more than 2 to 3 millimeter at the isthmus, approximately 60% of ascending aorta, distal arch 50%, and 40% if you get, then it is the hypoplasia. So abdominal aortic Doppler, from which we have dampened or the blunted flow patterns with flow persistent into diastole. It is important to perform pulse width Doppler assessment via an angle most parallel and least perpendicular to the angle of the abdominal aorta. Detailed assessment of the left-sided structures, because left-sided obstructions are very common with the coarctation of aorta, like the mitral valve, Z scores, aortic valve, left ventricular diameters, as well as the hypoplasia Z code, and also the bicuspid valves, which is the aortic valve, whether it's a bicuspid valve or what, hypoplastic. Then is the assess for the ventricular septum, because ventricular septal defects are common with detailed sweeps, and you have to assess from parasternal, apical, and subcostal views. RV function, ductus arteriosus is another very important thing in case of, in the background of coarctation of aorta. Assess for the right and left heart disproportion. Atrial communications, pulmonary hypertension if present, because in the neonatal ages, pulmonary hypertension is very common. Detailed assessment of the right and the left ventricular systolic function is also very known, is important for critical coarctations. Z scores, the tracheal, this is something which is for the fetal echocardiography, when to assess, and for the suspecting coarctation in fetal echo. Thank you for your attention.
Thank you, Ishita. And before we go to the next session, could we go back to our slides? Yeah. Ishita, can you just tell us, just summarize, what are the, in an echocardiography, what are the important things that we look for? Suppose we come across a coarctation. So what are the other associated anomalies that we must rule out?
So when we are seeing for a coarctation of aorta, first things and foremost, we will see for the left heart sides, the mitral valve. Mitral valve, whether the annulus measurements and the Z scores, especially for the children's, Z score is very important. Take the height, weight, there's an app, Z also, where you can put and get the Z scores. Then is the LV volumes. Then is the aortic valve, which is very important, because bicuspid aortic valve is most common association with the coarctation of aorta. Look for the aortic annulus. The arch, what type of arch it is. Arch hypoplasias are associated. The treatment modality changes to a lot of extent if you get an arch hypoplasia associated with a coarctation.
And
LV function.
why are you going back to this? So this is basically summarizes it. And various levels of aortic stenosis also, the valvular as well as subvalvular stenosis. And we also have to rule out the complex lesions like DORV, HLHS may be associated. Ventricular function is also important. And as you correctly said that it can be detected way back in fetal echo also. So how to assess the severity of coarctation, like how severe it is?
First and foremost, from the functions. If your functions are down, then it's the critical coarctation.
Yes.
And if the gradients are high and in the background of a good functions, then it is also a severe one. The narrowest segment index to the body surface area is also placed. If it is less than 50% and it is a 20%, it is pinpoint and it is very critical.
And also we have the complex ventricle physiologies where even a small gradient like 30 or so in a case of single ventricle physiology,
Yes,
that
it
would
is
indicate that it's a
significant
significant gradient across us. So do you want to add anything to it? And of course, what happens in cases of multiple sites of obstruction?
Suppose you are getting, usually in coarctations, when you are getting obstructions at various levels, whether it is a mitral valve, aortic valve, or other places, usually we go for the surgical managements. And if you are getting only in the aorta at various levels, you are getting obstructions. It
As
is
in Takayasu's,
it's
etc.
like, yes, because in that case, it is unlikely that it is a congenital one. It is usually the Takayasu component, which is not very uncommon in this Asian population. Even as early as 18 months, we get patients with the aortoarteritis in the children who present with various, especially the middle aortic syndromes, the renal artery stenosis parts, and the proximal part of the descending aorta where the occlusions are there.
Thank you. And due to the lack of time, we'll quickly skip to the next presentation. That is Dr. Rishita Mehta, who is the consultant of Narayana Super Speciality Hospital. She'll be speaking on single ventricle complexes.
So I will take this opportunity. Those who are staying today, I will request them to please collect your card from the reception area or the registration area. So those who are staying today, or to all the delegates who are staying today, please staying today for the banquet. I will request everyone, those who are staying here for the banquet, please collect your cards from the registration or the reception area. Over to you, ma'am.
Good evening, everyone. First of all, I would like to thank the organizers to give me an opportunity to speak on behalf of my teacher and guide, Dr. Amitabh Chattopadhyay. So, the topic for today I was given was single ventricular complexes. The topic itself is very complex and I couldn't understand where to start. So, I'll be just focusing upon the echocardiographic features of single ventricular complexes. So, basically, single ventricular complexes include double inlet, single inlet, or a common inlet. And as we know, it's all about the commitment, the 50% rule of the IVS and the IES. So when the AV annulus overrides more than 50%, there is a predominant connection to that ventricle. So what do we see in the echocardiographic evolution, which is important for the surgeon's point of view? So first of all, we would see the interatrial communication, which is important in for good mixing in a TGA physiology, a DORV, TGA type of physiology, or an obligatory shunt across the AV valve as in a tricuspid stenosis or a tricuspid atresia. So we want to see the size of the septum in 2D and its Doppler interrogation. It is important whether we want, before a Glenn shunt, whether we want to go on a pump or we don't want to go on a pump. So if the atrial septum is very small, we would plan an atrial septectomy. So that would be a BD Glenn with an atrial septectomy. So these are we have an restricted interatrial septum in this particular slide. Next, we would like to assess the AV valve regurgitation. More is the AV valve regurgitation. Our outcomes are not that good. Next is the assessment of the bulboventricular foramen, that is the size of communication between the two ventricles. It is calculated by two orthogonal planes, mainly the plaques and the subcostal views, and their mean is taken, and if the area is less than 2 centimeters square per meter square, the bulboventricular foramen is defined to be restrictive, and we consider enlarging of the bulboventricular foramen along with the Glenn shunt. Rootability assessment, though we view it visually, but this Japanese paper gives a kind of objective assessment. The length between the interventricular septum with the crest of the interventricular septum along with the aortic valve, it is compared with the left ventricle end diastolic length, and if it is less than 80%, we can go for a biventricular physiology, and if it is more than 80%, we'll go for a single ventricular pathway. And along with that, assessment of the systolic and diastolic function is very essential. So single ventricular assessment is not just an anatomical diagnosis, but the feasibility of repair when we go along the pathways of a Fontan completion. There are various forms of univentricular connections and associated abnormalities with it. Heterotaxies are an important subset which are important for a single ventricular pathway. The right atrial heterotaxies and the left atrial heterotaxies both are associated with situs ambiguous, and in a right atrial heterotaxy syndromes, it is associated with an uninterrupted IVCs, TAPVCs, and asplenia syndrome along with pulmonary stenosis and atresias. So this is a picture which shows the situs ambiguous with aorta and IVC on the both on the right side of the spine. And in a right-sided heterotaxy, the IVC is uninterrupted. It is important to see the hepatic veins, how do they drain, whether they form a single cuff or they drain separately. It is important at the time of a Fontan completion. So, because they are also associated with TAPVCs, we have to see the pulmonary venous drainage, which is very important to see before a Fontan or a Glenn shunt. And left atrial heterotaxies are associated with an interrupted IVCs. So, it is important that the patient will go for a Kawashima shunt, which may or may not in future go for a Kawashima completion of Fontan. So, that is important. The visualization of IVC is very important in the left atrial heterotaxy syndromes. It is usually associated with polysplenias kind of thing. So this is an interrupted IVCs with a hemiazygous condition. This particular child will go for a Kawashima operation. An important thing is to assess the size of the SVCs and the that particular side of the pulmonary artery. So if there is a discrepancy between the size of the RSVC and the RPA or the LSVC and the LPA, that would cause post-operative complications like chylothorax after the Glenn shunt. So to assess both the SVCs and to assess the bilateral branch pulmonary arteries and its comparison with the size. So our next subset would be the common AV canal defects if they are unbalanced kind of. So they would usually go into a single ventricular pathway, or the AV canal defects which have straddling which is more than grade A, like grade B or grade C straddling. Epstein anomaly type B or type C would go for either a 1.5 ventricle repair. Epstein type D would definitely go for a single ventricular type of repair. So crisscross heart, they are a very complex kind of lesions which would mostly go for a single ventricular repair because they are associated with high degree of straddling like conditions. A large VSD which would be from an inlet to outlet extension will definitely go for a single ventricular physiology. And to assess the rootability, as I said, though visually we can see that whether the VSD is rootable to the aorta, but still an objective criteria would be would give us a better knowledge about that. So in a DORV VSD kind of situations, when there is a non-rootable aorta, that when we swipe from the VSD to the aorta and we see that the VSD is totally closed and both the great vessels are arising totally from the right ventricle, we'll subject this patient to a single ventricle kind of pathway. A large VSD amounting to single ventricle would go for a single ventricle Fontan completion. Next of our categories would come either a smallish left ventricle or a smallish right ventricle. A smallish left ventricle or smallish right ventricle can be associated with mitral atresias or can be associated with complete AV canal defects. That would again go for a single ventricle kind of completion. So here we will compare the size of the tricuspid and the mitral valve, as we can see in our last clip. So mitral atresis and tricuspid atresias, though in Van Praag's classification, were not considered in the single ventricle kind of thing, but now they are considered. It's not moving. So mitral atresias and tricuspid atresias would go for a single ventricle kind of completion. Mitral atresias, hypoplastic left ventricle, they are basically a formifester HLHS. So to assess them for a Norwood kind of situation is important for us. In these conditions, the PFO would be obligatory, a left to right shunt. And if there would be a mean gradient of more than 12 mm across the PFO, that would be suggestive of a pulmonary venous hypertension. Always the DORV VSD kind of thing associated with PS is a welcome situation, because still they can go for a single ventricle pathway. But if the PS is adequate, they would land up in a severe PH kind of condition, which are probably not suitable for a single ventricle pathway. Hypoplastic left heart syndrome, as I said, would go for a Norwood kind of operation. Tricuspid atresias with restricted pulmonary blood flow, there are classifications, but tricuspid atresias is a better subset. And tricuspid atresias with a non-restrictive ASD with the right to left shunt is important for us. Otherwise, we'll have to subject the patient to a atrial septectomy. What is important for us is to see whether the pulmonary stenosis is adequate or not. Only then we can subject the patient to a Glenn shunt, because usually now in children less than 1 year of age, we do not subject the patient to a pre-Glenn kind of CAT situation. So an echocardiographic assessment is very important for us before subjecting the patient to a pre-Glenn Glenn surgery. Pulmonary atresias, complete AV canal defects would always go for a single ventricle kind of situations. We know that double inlet left ventricle are the most common kind of univentricle heart. Almost 78% of single ventricles are double inlet left ventricles. One more thing which is important for us to visualize is the AV valve stenosis. These are the conditions which we have an aorta and pulmonary artery from the right-sided chamber, but the bulboventricle foramen is not restrictive. This is a welcome situation for us. Routability is important to subject the patient either to a single ventricle or to a biventricle pathway. So, we've already discussed about the DORV situation. What is important is that whether the VSD is an inlet VSD, whether there is probably straddling or not. If there is straddling, we'll better like to subject the patient to a single ventricle pathway rather than going for a biventricle repair. So to summarize, what is important for us for a single ventricle pathway is to see whether the ventricles are adequate or not, whether they are well functioning or not, whether we have an adequate PS, whether the branch PS are adequate or not, and how many SVCs the patient has, a left SVC or the right SVCs, and associated abnormalities like coarctation of aorta, because tossing beam kind of associations are very closely associated with the right arch and coarctations of aorta. So there are various kind of morphological variants of unbalanced common AV canal which will always go for a single ventricle pathway, and probably because of short of time I would not be able to continue for how many single ventricles we can go on having.
Thank you, Dr. Ishita, for your nice presentation. I was just wondering, how do you assess the ventricular function in case of single ventricle scenario? Echocardiography.
So those would be similar as we go for the biventricle pathway. We'll assess TAPSE as we go for the assessment for the biventricle pathway, because the biventricle hearts, it's not much of a difference as the single ventricle or a biventricle kind of echocardiographic association.
Because in biventricle, we usually assess the longitudinal function by TAPSE in right ventricle, and we assess the overall by for Simpson method. We measure how is the left ventricular end-diastolic volume and the end-systolic volume and calculate the ejection fraction. But how do you do it in a single ventricle?
So for a single ventricle, we go for the same. We measure the TAPSEs for the right ventricle, because in an Indian scenario, the DILVs is the most common kind of single ventricle, and DORVs are the other thing which is the common associations. So TAPSE and ejection fraction would almost be as good as assessment during the biventricle.
So just to wind it up, the single ventricle complexes very nicely would enumerate these things broadly. And on the right is the picture of a typical pulmonary atresia and confluent branch BAs, which is very important, because the most important thing would be, as sir stated, the function and the pulmonary anatomy as well as the pulmonary pressures. So these are the important things that we should assess pre-operatively, and definitely we do need further catheterization and all. We should not forget about the extracardiac abnormalities like asplenia, polysplenia, heterotaxias, etc. And just could you, and you showed beautifully the various cardiac anomalies in the isomerisms. Just could you enumerate the important things that we should be aware in cases of single ventricle complexes?
We should be aware about the fact that because the basically in the situs ambiguous kind of situations, the right and left atrial isomerisms are associated with pulmonary venous anomalies. So it is important that we should see that whether it is a TAPVC or whether all the pulmonary veins are draining into the heart, or whether they are draining, forming common chamber, not draining directly into the heart. Also, the visualization of SVCs is important. We cannot miss an LSVC, because that patient will have to go for a bilateral BD Glenn. So these are important.
Also interrupted IVC for
a Kawashima completion.
Left atrial isomerisms. So we are not discussing Glenn and Fontaine further, because that would only complicate further issues. I think, sir, we'll just call it a day now.